Good evening, everyone. I'm Tony Segreto, and once again, so honored to be your moderator for tonight's In the Know Town Hall. We welcome all of you. You know, tonight we're going to be discussing a topic of utmost importance, especially for those of us living here in sunny South Florida. We're talking about skin cancer prevention and care. Did you know that 1 in 5 Americans will develop skin cancer in their lifetime? Think about that. 1 in 5. That's a staggering statistic. And it's all about the sun's harmful UV rays. That's the main factor in developing skin cancer. And that's not great news for those of us who enjoy our days at the beach, especially we have Memorial Day coming up. You know, as we enter the summer months, I'm sure we're all wondering the same thing. How do I protect myself? How much SPF do I really need? Do I still need sunscreen if it's cloudy outside? And many more questions. And what are the warning signs to look out for? And what are the best treatment options if I develop skin cancer? Well, fortunately, we're in the right place tonight and in South Florida and around the country because we have all of those questions answered for you, because we have put together an incredible panel to discuss this pressing topic, including the latest screening approaches for early detection, as well as innovative therapies proving effective. You're going to hear from renowned experts from Sylvester Comprehensive Cancer Center, which I'm sure most of you know. If you don't, you should, is the only NCI designated cancer center in all of South Florida. The panel tonight is led by Dr. Jose Lutsky, Director of Cutaneous Oncology Services and Medical Director of the Clinical Trials Coordination Unit at Sylvester Comprehensive Cancer Center, and the Professor of Medicine at the Miller School of Medicine. He'll be joined by Dr. Natalia Jaimes, Professor of the Dr. Philip Frost Department of Dermatology and Cutaneous Surgery. Also joining the panel tonight is Dr. Neha Goyal, an assistant professor of surgical oncology, and Dr. Leo Hernandez, assistant professor of clinical medicine at the Miller School of Medicine. Doesn't get any better than that. It is truly a world-class group of experts. I'm excited. I hope you are too. But before we get started, let's go over how you can participate in tonight's conversation. After Dr. Lutsky has delivered his opening remarks, all the panelists will answer the questions that you've submitted over the last few days. But you're also going to have the opportunity to submit your questions during this program live. So for those of you who have joined us before, you know the drill. For those of you who are new, it's really simple. At the bottom of your screen, you're going to see a Q&A feature there. That's where you send us your questions. We want to remind everyone again, all the questions submitted will be anonymous, and we promise, we really do promise to get to as many of them as we possibly can. But in order to do that, we have to start our program. And to do that, it is now my pleasure to introduce Dr. Jose Lutsky. And Dr. Lutsky, we know how busy all of you are. It is just an honor to have you here and for you to take the time to be with us.
Good evening, and thank you, Tony. I'm delighted to join you tonight. I'm honored to speak on behalf of our faculty, physicians, and staff at Sylvester Cancer Center in the School of Medicine. It's a privilege for my colleagues and I to share our expertise, experience, and research with you tonight. As you said, it is true that skin cancer is the most common type of cancer that we see in the United States today. Basal cell carcinoma is the most common form, and there are about 3.6 million cases diagnosed in the United States every year. The second most common form is squamous cell carcinoma, with an estimated 1.8 million cases in the US every year. Fortunately, there are preventative measures that you can take to reduce your risk of developing skin cancer. And that's why education on this topic is so vitally important. If detected early, most skin cancers can be very treatable. And tonight we will discuss early warning signs that you should be aware of, as well as the importance of skin screenings. Our team at Sylvester Comprehensive Cancer Center is a regional leader in early detection and treatment of skin cancers. And we have a world-class melanoma surveillance and detection clinic, which helps to identify melanoma when it's most treatable. We continue to advance research and clinical trials to provide better outcomes for patients, both in the early and later stages of skin cancer. Our goal tonight is to answer your most pressing questions about the causes, prevention, and treatment of skin cancers. And we look forward to answering your questions tonight. Tony?
Dr. Lutsky, thank you so much. And we're going to start. Dr. Jaimes, you are in the hot seat first. Welcome. It's nice to see you again. We had you when we did our webinar, our In the Know on dermatology. So the first question is the basic one. What is the best form of protection to prevent skin cancer?
Well, hi, Tony. Nice seeing you again, and welcome everyone. Thank you for joining us today. So I think there is not a straight answer, but it's a combination of some of them. So how can we protect ourselves from sun exposure? So it's the combination of one, using clothing. That means hats, sun protective clothing. If you have sunglasses, remember they had to be wide brim so that you can cover your ears, the back of your neck. The glasses, we want big ones so that you also cover the skin around your eyes. Sun protective clothing, there are very nice models with all designs, so very with sun protection factor. And then we can have also sunscreens, and there are a broad variety. Ideally, if you're outside, broad spectrum, which means we are covering UVA, UVB. There are also others that also protect from visible light, ideally water resistant, and don't forget to reapply every 2 hours, especially if you're going to be really outdoors. Sometimes we forget. And obviously seek the shade, don't use tanning bed. And remember, even here, when we have those cloudy days, don't forget to apply it. That's when more sunburns we'll start seeing, because it's just the freshness, but sun is there, and that's when we see a lot of sunburns. So those are like little clues that you need, the combination of all of them.
Thank you, Dr. Jaimes. And I'm glad you mentioned cloudy days, because I learned that a while ago. You never know on a cloudy day that you're gonna, how did I get sunburn without the sun coming out? Dr. Lutsky, we're gonna have you back in for this question. Are there new drugs recently approved to treat advanced melanoma?
Yes, indeed. In fact, there was a new drug that was recently approved to treat melanoma. It's a new type of immunotherapy drug. As you may or may not know, immunotherapy has really revolutionized the way that we treat melanoma, particularly advanced melanoma, and also to prevent recurrence of melanomas that are at high risk of coming back. This new drug adds to the armamentarium that we have, and it's just one more drug that will help us fight this disease, for which we have made tremendous progress already.
Thank you, Dr. Lutsky. Dr. Hernandez, we welcome you. Nice to see you tonight, sir. Can you give treatments for melanoma before surgery to shrink the tumors?
Hi, Tony. Thank you. Thank you so much for having me, and thank you all for joining. So I think this is a very interesting and important question, and very relevant to the research that we're doing here at Sylvester. So typically, the treatment paradigm for melanoma has been to remove the tumor by surgery and then discuss if we need additional treatments to decrease the risk of the cancer to come back. But lately, we have seen that with the new and potent treatments that we have, for example, immunotherapy, we can actually give these treatments before surgery with the goal to reduce the size of the tumors and actually facilitate, the work for our surgeons. And this is especially important, for example, when our patients present with large skin cancers, or when the cancers have a spread to regional areas. So I think, again, this has been a very important part of our research efforts, and we have new treatments, new medications that we are using. And we have seen amazing, responses actually with these new treatments, because basically we can give them to the patients, and then we can see those tumors sometimes, shrinking in real life when we examine the skin of our patients. So, and then when they go to surgery, sometimes they don't even find any residual cancer. So here at Sylvester, again, we are investigating this approach. So, and we take this into consideration for each patient, because obviously each patient is unique. And we discuss within our team of multidisciplinary team of doctors, what will be the best treatment if we do surgery first, or if we try these new treatments before.
Thank you, doctor. Just absolutely fascinating. Dr. Goyle, we welcome you. We hope you're doing well. Thank you for your time tonight. The question for you is, what is the role of a surgeon in melanoma care?
Excellent. Thank you so much, Tony, for the warm welcome. And this is an excellent question. So the role of a surgeon is really to assist with curing the disease. And so how do we do this? So there's 3 different steps that we do. One is managing the melanoma locally. So that means if someone presents to us with a melanoma that has been diagnosed, we remove the melanoma with very strict criteria in terms of the margins that we take. And this is all based on national studies. And then we check the lymph nodes, and the lymph nodes are basically tissue that can be located in the head and neck area, under the armpit, or the inguinal areas. And these tissues or lymph nodes, we remove the first set of lymph nodes that disease would go to, and those are called the sentinel nodes. They kind of serve as the first defensive line. And we remove those to see if there's disease in those areas as well. So that's what we call local control of melanoma. We also assist with disease that might have spread to multiple areas along the arm or the leg. And we do this with a specific treatment that we offer here called isolated limb infusion. And that's really giving treatment specifically just to that location of the arm or the leg to help assist with removing disease that might be there. And we also, as mentioned before, we also offer additional treatments with neoadjuvant chemotherapy. So this is a new area where we once again try to see if the disease that might be located in other areas, such as that have spread to the adrenal gland or different parts of the body, if we give them immunotherapy or treatment before surgery, if the disease can shrink, and then we can offer them surgery of that additional area that might not have been possible before. In addition, we have cutting edge surgical options that try to limit the risks or complications of surgery. We offer minimally invasive lymph node dissection. So in cases where disease might have gone to the lymph nodes and we need to remove the lymph nodes, we'd really try to offer our patients the best surgical treatments that will limit the complications that they might have after surgery.
Our audience might be wondering how we make these decisions, right? Yeah. And I wanted to stress that all of us meet essentially every week, and we discuss every new case of melanoma that comes across one of us, and we make those decisions jointly. And that's, I think, another advantage of having, being cared for in a place where there is multidisciplinary care. So we make all these decisions jointly, and that's the way where I think we get to the most appropriate treatment for these patients.
Yeah, that's impressive. Dr. Jaimes, I saw you nodding while Dr. Lutsky was talking. Would you like to add to this?
No, it's just that it's very nice that we kind of meet each week, and it's just one of very advantage of being in this cancer center. So for the patients and for us, obviously, we have something we want our colleagues to give feedback. Maybe they have more experience with this or that. So it's a very educating for us as well. So it's for the benefits of patients, for us and our training students, fellows, residents. So it's a win-win for all the time, for every part, every perspective. It's a win-win activity we do.
Yeah, that's great. In fact, Dr. Hernandez weighed in on that with his first answer. Dr. Jaimes, we have a question for you. How can I check my skin at home, and what do I need to look for?
Oh, this is key, and I'm glad they are asking this, because everything starts by us. So first of all, we all need to know about our skin, and I think that's one of the key components in early detection. And basically, I'm not going to go over what many of us have read A, B, C, Ds, and the symmetry board. It's as easy as knowing your skin. And if you see anything new or anything changing, then that's what you want to bring out to the physician's attention. And new being something, a lesion that was not on your skin develops and it doesn't go away, stays for more than 1 month. And especially if that continues to grow, then we want to see it. And also, we also look for any change in shape, color, form. It was flat, it's getting raised. So any change, we also want to see it, especially in those high-risk patients. So anyone with new or changing, regardless of the color, because we also have pink, black, and brown melanoma. So regardless of the color, that's how I can summarize it. But you need we need to empower ourselves to really check our skin and get to know it.
Well said, Dr. Jimenez, thank you. Dr. Lutsky, is age a factor in deciding the type of treatment in patients with melanoma?
I think it is a factor, but I think it needs to be individualized. Some of us have a biological age that doesn't correspond to our actual age, and vice versa. So most of the treatments that we use to treat melanoma now are very effective, and they have very tolerable toxicity, even for older patients. We find ourselves treating patients in their 80s and 90s and getting away with it with just as good responses as the younger patients. And indeed, there is data that shows that the toxicity of these treatments in older patients is not any different than the toxicity in younger patients. So it's a factor. It needs to be individualized. But for most patients that actually need that treatment, it usually can be done.
Fascinating. Dr. Hernandez, we're going to bring you back. And the question goes like this, with an added part to this question that was just sent in. What are some differences between chemotherapy and immunotherapy? And are there any new developments in immunotherapy?
Yes. And I think it has, a little bit of relationship with the previous question, because we used to treat cancer with chemotherapy was kind of the only systemic way to treat cancer, or the main drugs that we used. And chemotherapy basically works, killing cancer cells directly, but it attacks really all rapidly dividing cells within the body. So there could be cancer cells or normal cells. And when chemotherapy affects the normal cells, that's when we see the usual side effects that we see with chemo. So for example, hair loss, diarrhea, fatigue. But immunotherapy, on the other hand, is a treatment that empowers the patient owns immune system to fight cancer. So we're basically using your own immune system to seek out and destroy those cancer cells. So because of that, and the differences of the treatments, we have seen that with immunotherapy, we can actually provide sometimes long-term protection against cancer, because the immune system has not only the ability to recognize and kill the cancer cells, but it can also remember, how those cells, look like. And this immune memory is what makes that sometimes we get long-lasting remissions. So I think those are the key differences, and that's why for melanoma and most skin cancers, we're now using immunotherapy as the first line of therapy.
Great, thank you, Dr. Hernandez. Dr. Goyle, are there any injectable treatments for melanoma?
Yes, Tony, there are. So this is an excellent question. For a disease that has spread to multiple areas of either the leg or the arm, and if we can't remove all of those lesions, there might be 10, 20 areas. Sometimes we do use specific treatments where we inject an oncolytic virus that can actually kill the disease in those areas. And that really helps to attain local control and provide treatment in cases where there might not be other options.
Yeah, this is just fascinating as we go on. And Dr. Jimenez, I'm going to bring you back in. This is kind of a two-part question. The second part was actually just sent to us. First part is this: are there any aids that I can use at home to check my skin? And then the second part was, do clothes with sun protection, because you mentioned that in your first answer, do they lose their effectiveness with multiple washings? And should one wear sunscreen under that type of clothing?
All right. So to the question about what can we use at home. So there are many, things basic. Obviously, you can use a mirror. You can use a hair dryer that is always told to be used. But I think, and for me, one of the most important things is photos. That will help you. Sometimes we don't recall. So having pictures of yourself, challenging sites, like your back, that will help you. So those are like aids that you could use, but obviously, and if you have someone that can help you, that will also be good. So if you have pictures, have them as baseline, and then from there, just compare your pictures, and that will help. Basically, you don't want to see anything new or changing when comparing those pictures. Now, going to the second question, yes, sun protective clothing do lose their sun protection factor. Every time you wash it, you get in the ocean, the pool, so it starts to lose it. And for me, not necessarily. You don't need to actually use your sunscreen below your sun protective clothing. That's one of the advantages, to be reapplying underneath it. Obviously, if it's now very thin because it's all with a lot of washes, probably you will need some sunscreen, but if you have a good clothing, you should be okay. So just sun exposed area, that's how I usually recommend it.
Before we go to Dr. Letsky, I've got to ask you, does SPF 30, is that different than SPF 100? I mean, does 100 give us the best, or does it matter?
So there are several studies showing that, and from 30 to 100, yes, there is a difference. But for the daily, at 30, it's okay. But if you're really going to be outdoors, anything above 50 or even 70 has been shown to be very close to 100. So above 70, you can be okay. So you don't need to go to 100, and that should be fine.
Thank you. One of those things you always wonder, you're kind of inundated with all these different.
Yeah, you go for the highest number. That's what it is.
Exactly.
Same price, and which one should I go? Let's go for that one. But above 70, if you're going to be outdoors, swimming, whatever, hiking, you should be fine with above 70. I prefer like creams, but that's okay.
Thank you, Doctor. Dr. Letsky, how does one handle melanoma that keeps coming back around the same area as the original melanoma?
Yeah, well, I think partly the question has been answered in a way by Dr. Goel. Obviously, the first thing we want to know is if you can surgically excise that melanoma. But sometimes, as she mentioned, there are many areas around the original site that come back and becomes difficult or impossible to excise them surgically. So in those situations, one thing that we can do is to use these oncolytic virus that not only kill the tumor in the area where you inject it, but they elicit an immune response that may kill the tumors in areas that are not injected. So that's one option. Another option is to use what Dr. Hernandez alluded to, neoadjuvant treatment, which is using immunotherapy to see if we can shrink those tumors and then maybe use another type of more permanent treatment. So there are a lot of different situations, different presentations. And again, we like to discuss all of these in a group where we hear everybody's input.
Thank you, Dr. Letsky. Dr. Goel, I saw you nodding your head there. Would you like to add something to that?
Yeah, the only thing I would add was similarly, and I'd mentioned it earlier, was the isolated limb infusion. So it's a treatment that if there are multiple areas of disease that have come back, and for example, the leg, where we can actually inject high doses of chemotherapy that the body may not tolerate, and we just inject it in that one extremity to reduce the toxicity that it might cause. And we have seen good responses. So once again, as Dr. Letsky mentioned, there's absolutely treatments that we offer here. And there's always clinical trials where we're really trying to push the envelope from a research perspective and offer novel treatments for our patients.
Great, thank you, Dr. Goel. Dr. Hernandez, what are the more frequent side effects that I can experience with immunotherapy for skin cancers?
Yes, Tony, very important question, because as was said earlier, we are using a lot of immunotherapy to treat our patients. And the side effects of immunotherapy usually happen because we are overstimulating the immune system. But sometimes those immune cells, that we want them to go and attack the cancer. Our goal is for them to go and attack the tumor cells. Sometimes they could be misdirected, or they just can go kind of off target, and they can affect normal organs. So when we give these treatments, we monitor our patients very closely to try to detect those adverse events early, and we can treat them. So basically, the side effects vary according to the type of treatment, and they can affect different organs. But as I said, if we monitor our patients closely, we can detect them early and start treating them. One of the most common we found adverse events are like, rash in the skin, itching, and that happens because those immune cells, can go to the skin and cause those symptoms. Some patients may develop diarrhea or cough, fever, like flu-like symptoms. But again, those are monitored, and we can provide treatments for those side effects. It's important to emphasize that while some severe side effects are uncommon, when they occur, they can be, they may require immediate medical attention. So we recommend that, to all our patients to call us, immediately if there are any symptoms or signs that there might be something going on. And again, I think it's just very important to diagnose them early, to start treatment as early as possible.
Thank you, Dr. Hernandez. Dr. Goyle, this was just sent to us. Is it sometimes appropriate to monitor a basal cell lesion in lieu of immediately removing it?
Well, thank you for that question. And I'll also have Dr. Jaimes chime in from a dermatologic perspective. I think by the time a basal cell is sent to a surgeon, we're often it's been deemed that it needs to be removed. And so in terms of observation, I don't think we would necessarily recommend observation.
Dr. Jaimes?
So that's a very good question. And probably if you go to the guidelines and everything, they will state a lot of treatment, and like guideline, first-line treatment surgery. Then you also have topical treatments like creams, photodynamic therapy, scraping, freezing. But to be honest, I think these are, if they're small, right? So we're talking small tumors. There are some patients that if we discuss and we have this discussion, we can follow, especially when they have other comorbidities, things going on. We need to prioritize other things. So sometimes they grow so slowly that it would be okay to wait and not monitor, but we know there, obviously, we are talking about small basal cell carcinomas, not the ones that really require treatment. So yeah, guidelines will tell you treatment, and but it needs to be a base-to-base why patients want to monitor on what's going on.
Dr. Jaimes, stay right there because we have a number of questions for you here. It's actually a number of questions within one. The last two were just literally sent in. So first part goes like this. What systems or tools are used to follow people with multiple moles or those at high risk for skin cancer? And when it comes to the sunscreen, because you had talked about this before, are there ingredients that I should look for to avoid given possible toxicity? And how often do I reapply with the higher SPF?
So regarding the tools, so one, and there are some keywords in the question which are high risk patients or patients with multiple moles. So that's a high risk patient, which means they have a higher chance of developing a melanoma or other skin cancer. And with that, it's very important that when we use these systems that I'm gonna just briefly mention, we select the appropriate patient for the appropriate diagnostic tool or the method that we're gonna use, which can be total body photography, also known as mole mapping. There are different devices. We have 2D images, 3D images. And there we also have a tool that is called dermoscopy, which is like a magnifying glass that allows us to see underneath the skin. And so we take pictures of those to the moles. And if we attach those pictures of the moles to your total body photography, then that's what's called mole mapping. And we used to follow patients in time, their skin and their moles, to basically see if there is anything new or changing. We have other tools like confocal microscopy, which allows the visualization of, let's say, in vivo cells for very specific lesions, especially in those high-risk sites. So yes, there are things that we can use, and the patients also can use these, let's say, photos and images at home to make part of the team, because as I mentioned earlier, it's very important, the participation of the patient in their skin check. And now if we go to the sunscreens. So there are different components. Very broadly, we can divide the components in, let's say, organic or physical, which basically they reflect the light from your skin. And there are only two, which is zinc oxide and dioxide and titanium dioxide. So basically the children's sunscreens are based on that, for example, but there are others that also only use that. So if anyone has any concern, this chemical component, I'm not sure, like the environment, so anything, well, I would just say go for these two types, and then you should be on your safe side. And then we can have the combination of those two organic or physical components with the chemical ones, which they act, their mechanism is a little bit different. So they kind of process the light in their skin and different from reflection. But obviously those get a little absorption. So I say, if any concern the patient, the to-go will be just go for any of the two physicals, and then that should answer their question, I hope.
And how often should we reapply?
So ideally every 2 hours, but obviously if you're swimming or sweating or hiking, well, reapply after swimming or taking a shower, but if not, just every 2 hours if you're going to be outdoors.
Great, thank you.
Even in cloudy days.
Thank you, Dr. Jaimes. It's so fascinating. Dr. Lutsky, we have a couple here. One was just sent in for you. The first part goes, does immunotherapy work for skin cancers other than melanoma? And then, are there any statistics on relapse for cured metastatic melanoma Keytrude for the survivors there? I was cured 5 years ago.
Yeah, in regards to the first question, the answer is yes. Immunotherapy also works for skin cancers other than melanoma. As we mentioned in the beginning during the introduction, basal cell carcinoma and squamous cell carcinomas are the other two common types of skin cancer, actually more common than melanoma. And basal cell carcinomas, as Dr. Jaimes earlier alluded to, tend to be slow growing, but sometimes they are not. Sometimes they grow, they invade deeply, they can even metastasize to the lymph nodes and rarely to other organs. And when that happens, treatment options become more limited. It could be radiation therapy, but more recently, immunotherapy has been found to work in basal cell carcinomas that are advanced, as well as squamous cell carcinomas that are advanced and cannot be treated with the usual forms of treatment like surgery and radiation. So there's actually very good data now, and these treatments are approved by the FDA to be used in these cancers. In regards to the second question, would you mind repeating that, Tony?
Sure. Let me go back to it. It was just sent in to us. Are there any statistics on relapse for cured metastatic melanoma Keytruda survivors? Yeah. I was cured 5 years ago.
Yeah. Well, if you're using the word cure, right? So it shouldn't be any relapse by definition. As oncologists, we are brainwashed from the very early days of our training not to use the word cure in vain. So we're very, very reluctant to say someone is cured. But with these treatments for metastatic melanoma, what we have seen trial after trial after trial is that usually starting around year 3 that patients are in remission, there tends to be a stabilization in the survival curve. So we see very, very little difference in relapses between 3 and 6.5 years, which is the longest interval that we have now. I think we're beginning to use the word cure now. And I would say to this person in the audience that he or she, can sleep, and be quiet and really not worry about her melanoma at this point, although she or he should continue to follow up with their doctors.
Dr. Lutsky, you should know that when you said we're starting to use the word cure more, if you would have seen the smiles on Dr. Jaimes, Dr. Hernandez, and Dr. Goyle, it was remarkable. It just, you're gonna have to retrain yourself. Would any of you like to weigh in on that real quickly? Because I know you all sort of reacted to it. Dr. Jaimes or Dr. Hernandez, Dr. Goyle?
Yeah, I can weigh. I completely agree. I think that the fact that these new treatments can develop this long-term memory, and keep looking for those maybe cancer cells that may develop for many years, has given us that scientific basis to think about a cure for melanoma, and there are the initial patients that we treated in clinical trials, even 10 years, 12 years ago. There are some patients that had a stage 4 melanoma, 10, 15 years ago and participated in those initial trials that are, coming back to see us, which was something that was, obviously not seen prior to immunotherapy. So, so it's very exciting to begin using the word cure.
I just want to say something, because actually after all patients, let's say, are discharged from surgery, from oncology, we end up, I say, like, you're going to be dermatologist patient for the rest of your life. And it's really a honor, so fascinating. I'm so grateful to be like part of their journey and see them after so many years. So it's really like a pleasure and real honor to see them in clinic when they are like so many years after that. I want to say just one thing with that I kept thinking, like the basal cell carcinoma monitoring. So I think the message should be case by case. So obviously we can remove things, early detections. That's what I do and what we always encourage. If you just remove it and that's it. So if we don't want to keep monitoring something, obviously it's case by case, but at the end, it's a very, when they are small, it's pretty easy to treat. And we have great surgeons in dermatology and surg onc that probably that should be like the to go. But as I say, it's a case by case basis.
Yeah, Dr. Goyle, you have to, I know you want to say, your head was bobbing there pretty strong. Please tell me what you were thinking. Tell all of us what you're thinking.
No, absolutely. I think like everyone has mentioned, we've really come a long way with melanoma treatments in terms of even the surgical options for disease that might have spread elsewhere. And with immunotherapy, we can actually see how the disease responds and really, as mentioned, take these patients to surgery with disease that might have gone elsewhere that may have not been an option elsewhere in the past. So I think it's really the treatments that we really can offer our patients are excellent nowadays, and we're fortunate to have such an armamentarium to really help our population.
Great, thank you so much. Dr. Hernandez, we have this question sent in. Is it true that darker skinned people tend to get cancers under the soles of their feet and the palms of their hands?
So I think this question is pertinent to talk about a type of melanoma that is called acryl melanoma. So acryl melanoma is a rare type, it's a rare type of melanoma, but it tends to appear on the palms, soles of the feet, or under fingernails or toenails. And it's the most common type of melanoma that we see in among people with darker skin. So unlike the most frequently seen melanomas, this acryl melanomas is not. Those are not believed to be caused by exposure to the sun or UV radiation, but it's important to mention that this can begin as a patch or a spot or discolored skin that gets kind of bigger over time in those areas of the body. And they can grow and start, for example, under the nail bed and start kind of damaging the fingernail, or, you know, it can start as a streak, you know, of pigment in the nail. And so we frequently recommend, because there is, you know, kind of that misconception that melanomas only occur in sun exposed areas, and that people of, you know, of color are not at risk for melanoma. So this can be, you know, sometimes discovered later than other types, and they can be, when they are found, they can be invading maybe deeper layers of the skin, or even metastasize. So it's key to monitor the skin, and as was said earlier, any changes, any concerns with new lesions, even on the palms, soles, or under nail beds, you know, please consult with your dermatologist.
Thank you, Dr. Hernandez. Dr. Goyle, we had this just sent in for you, actually. How can you treat recurring squamous cell in legs even after Mohs surgeries? And what exactly is Mohs surgery?
Yeah, excellent. So I can, I'll help answer, and I'll have Dr. Jaimes answer as well. So from a surgical oncology perspective, a lot of the treatments that we can offer for recurrent squamous cell are actually more immunotherapy. So it's really treatment that might be offered as we would discuss a patient in our conference, and really try to see what treatments from a systemic point might actually help that patient. And as discussed earlier, when we do see patients that might have local disease that's aggressive, there's often immunotherapy that we can give to really try to help control that disease. And if it stays controlled for a certain amount of time, then we can actually offer surgery at that point. And we definitely work with our plastic surgeon. So even if a squamous cell has been resected multiple times, we do have options to work with our plastic surgeons to close that area as well. Along the same lines, if a squamous cell has certain high-risk features, then or if it's been recurrent, we can offer something called a sentinel lymph node biopsy and really check to see if that disease has also gone to other areas. But those are specific criteria for high-risk lesions as well. And then in terms of Mohs surgery, I'll let Dr. Jaimes answer that. But I wanted to mention one more thing regarding the in a darker skinned patients. In addition, there are melanomas that can occur in areas called mucosal areas. And so it can be in the anus, in the lining of the mucosa there, as well as in the nasal or nasopharynx area. So also if patients notice a discoloration or a darkening of the skin, not necessarily the skin of the mucosa, with inside their nose, that should also be worked up by a dermatologist.
So regarding the squamous cell on the legs, what treatment? So besides what Dr. Goyle already said, like Mohs surgery sometimes, and I think he was asked what is Mohs. So it's let's say a very briefly a type of surgery that is done by a dermatologist usually trained in that technique, where he's trying to take skin, trying to spare skin, especially in those high-risk sites. And they will be checking in the same time, in the same moment, in the operative moment, they will go and check that the margins are clear. So that will spare normal skin, especially in like face or legs or the fingers, genitalia. So Mohs surgery is usually for those high-risk sites. And also when we talk about recurrent squamous cell carcinoma or basal cell carcinoma. And the other thing that what else we use for squamous on the legs, I think, so it depends if it's in situ, for example, we have different options like topical treatments, some scraping and burning you can also do, but legs are special sites for me, and there needs to be some other things into consideration. But there are other treatment options, especially for those that are in situ, meaning they are just in the upper layer of the skin.
And if I can
Yes.
also mention that, you know, when this cutaneous squamous cell carcinomas keep coming back, I think that's also the benefit of being in a center where we can discuss our cases in our multidisciplinary conference, because, you know, frequently our dermatologists or surgeons, you know, present the cases, and we can all, you know, talk about maybe a clinical trial. We actually have clinical trials that we are combining immunotherapy with new injectable agents. So it's important to seek, you know, help in an institution like that has that benefit.
Great. Dr. Hernandez and Dr. Jaimes, Dr. Goyle, thank you. Dr. Lutsky, this was just sent in to us. How do you consider genetics in melanoma and other skin cancers?
Well, for melanoma, there are certainly some families that are more prone to melanoma, but they're the exception rather than the rule. There are some mutations in the genes of all cells that we call the germline, that can predispose people to have an increased incidence of melanoma. But those that are particularly increase the risk, particularly for melanoma, are very rare. You can usually tell if there is a familial trend by just taking a good medical history. Patients that have those types of genetic traits, they have melanomas at an early age. They tend to be multiple, they tend to be aggressive, and there is usually a very strong family history. Now, there are other genetic traits that may also predispose to melanoma. For example, patients that have a BRCA mutation, which is the mutation that increases the risk for breast cancer, that also increases the risk for melanoma. But the increase in risk for melanoma is not as high as the ones that have these other mutations that are more specific for melanoma. So the majority of patients that present with melanoma, the most common cause of that is really unprotected sun exposure, excessive UV radiation, with a few exceptions that were mentioned earlier. The melanomas of the mucosa, they have melanomas where the sun never shines, and the acryl melanomas, but those are less common. So yes, there are families that are more prone, but they're rare, and usually a good history can sort of sort out who needs to be tested for that and who does not. And I don't know if Dr. Jaimes has anything to add on this, because she's been studying
that. And in addition, we also know there are certain what we call phenotypes, how patients look, like fair skin, red hairs, how the color of your moles. So we can say, okay, probably there is this type of mutation here, but I totally agree with that. And there are specific criteria when we think, okay, we should send this patient and family to test. As Dr. Lutsky, they are the minor. I mean, it's the minority is not the majority of the melanomas. But yeah, also we see it from the skin cancer, the skin, how your skin looks and your family.
Thank you, Dr. Jaimes. Dr. Lutsky, stay right here. We want to just say something to our audience. We have done a number of these in the nose. Of all the ones we've done, we have never had as many questions submitted during the program as we're having tonight. So we want to thank all of you for sending them in. And we promise you we're going to get to as many of them as we possibly can in the final 9 minutes that we have here. Dr. Lutsky, you're up. I've been told that there is a treatment for skin cancer that involves sitting in a dark room with a blue light on for 1 hour and then staying out of the daylight for a couple of days.
Yeah, that's a phototherapy. This is, you take a medication that sensitizes the tumor to light, to specific wavelengths of light, and the light is applied to that tumor, but the rest of your skin is also sensitized. So if you go out in the sun, you get terrible burns. That's a treatment that's a problem in Florida particularly, but also we do not give those treatments. That's usually the dermatologists that do that. And maybe Dr. Jaimes can add to my comments.
So that's a photodynamic therapy. So there are two types of light in the US currently approved, the blue light. So what they do usually is put the cream on the skin or the lesion they want to treat. So let's say you have something on the face, so you put the cream, you let the cream work for a time. So it's not one day, and then you come to the light. I mean, that same day you then are exposed to the blue light. Times varies, whatever you are treating. And then your skin is going to be, wherever you apply that, if you go out, you're going to be a little bit more sensitive to the sun. So probably, I guess that's what the person was saying. So it's a treatment that we use for actinic keratosis for some types of skin cancer that are superficial. So that are in the very superficial part of the skin. And I guess that's what the person was referring to.
Great, thank you, doctors. Dr. Hernandez, this was just sent to us as well. Are there blood tests that detect cancer effectively and at identifying the presence of skin cancer?
So this is an area of active research right now, is to try to detect basically fragments of DNA of the cancer in the blood. So it's called circulating tumor DNA, and circulating because we detect that in the blood instead of having to do an actual biopsy of the tumor. So we're trying to identify, again, these fragments of DNA of the cancer in the blood to try to see if we can, for example, find new mutations from the cancer in the blood that maybe we can target, or maybe we could follow our patients with those levels and see, for example, we give them treatment, and if those levels go down, it can potentially give us an indication that the treatment is working for that particular patient. So those levels of DNA could be measured in the blood, but it is an area of research. It's not yet used in the clinic widely to make decisions about treatment, and it's not used to diagnose a skin cancer. So it's not that we will recommend you to go and have a blood test to try to diagnose the cancer. No, it's more in a specific clinical trials where we are testing that. So to diagnose the skin cancer is with a biopsy, with your dermatologist, and with all what we just have discussed.
Dr. Hernandez, thank you. Dr. Jaimes, this just sent in as well. Lasers, what are they best used for? And are lasers better than Mohs on the face?
So there is like many things in. So lasers, we use lasers in dermatology for different things, from photoaging, removing hairs, improving the redness or the little blood vessels of your face, improving scars. So there are different applications and indications. And no, it won't replace Mohs surgery. Sometimes what they do is they use laser, usually, let's say 6 weeks after surgery, to try and improve like the scar or something, but it's not that we are replacing Mohs surgery.
Thank you, Dr. Jaimes. Dr. Lutsky, is there a way to prevent the melanoma from coming back after it's been taken out by surgery?
Yes. So because of the great efficacy of these immunotherapies in patients that have widespread melanoma, or what we call metastatic melanoma, a number of clinical trials have been done to see if we could prevent melanoma from coming back after they were excised by surgery. And there we have to identify the people that are at highest risk, right? You don't want to give treatment to someone whose risk is very low. So we have identified those patients, and those are patients usually that have involvement of the lymph glands, or that have very deep and what we call ulcerated lesions. So ulcerated lesions is a feature that you see on the biopsy that it gives a higher likelihood that the tumor might come back. So right now we have treatments that we give after surgery. We usually treat patients for 1 year, and all of the studies basically agree that we can decrease the risk that the melanoma would come back by about 50%, which is a very good result.
Dr. Letsky, thank you. And, you know, we told all the doctors beforehand, for those of you with us, we told all the doctors beforehand that this hour would fly by. Doctors, do you agree that this hour flew by? It's
totally, yeah.
Yeah. Dr. Letsky, we have to hear some final comments from you before we leave this evening, and then we'll have some final thoughts for the audience as well. So please tell us your final thoughts.
Sure, give me 1 second. Well, I would like to thank everyone for attending this today. It really went by extremely fast, and you know there's a lot more that we could discuss and that we would like to have discussed with you. Please send in your questions, and we will try to answer them as it goes. And I thank Tony, and I thank the University of Miami and Sylvester Cancer Center for putting this together to help our patients. And I wish you all a good Memorial Day.
Thank you, Dr. Letsky. And Dr. Letsky, I have to tell you, just listening to all of these doctors, Dr. Jaimes, Dr. Goyle, Dr. Hernandez, you have quite a team behind you and with you. And it makes for great medicine for those using Sylvester Cancer. So thank you for joining us tonight. And thank you.
One last comment before you go to that beach on Memorial Day. Remember what we've discussed today, okay?
Remember the cloudy days.
All right, one more time. Every 2 hours, Dr. Jaimes, right?
Every 2 hours, water resistant, reapply, and watch out for the cloudy days.
Yeah, watch out for those cloudy days and look at the SPF, but you know, you can figure out that the lower ones are probably just as good as the 100% ones. So
over 70 if you're going to be outside, outdoors. So yes, yeah. For the weekend.
We could go another hour, easy. We want to thank all of you for participating in tonight's In the Know Town Hall. And I think you all have to agree. I mean, this has been a remarkable hour. And we hope that you feel the same way we do. And we're so proud to be a part of all of this. And we hope that we filled you with valuable information from talented and passionate doctors who are dedicated. You could feel it, you can see it, you can hear it, dedicated to keeping us safe and cancer-free as we enjoy the summer months ahead, and especially this Labor Day weekend. Please remember that a full recording of this program will be posted online. Look for the link in coming days. Also, in a moment, you're going to get a survey about tonight's town hall on your screen. Trust me, it takes about 15 to 20 seconds. Just take the time to fill that out, because what that does, it helps us understand your interest and improve our program. As always, we want to thank you for joining us. Have a safe Labor Day. Don't forget the sunscreen. And as Dr. Jaimes said, especially on those cloudy days. And as always, we wish you and your family nothing but good health. And remember, it's always about the you. Good night, everyone.